So we will be doing traumatic brain injury in children. This is Mike, Nathan, Schuyler. All right, so definition. It occurs when an external mechanical force accidentally or intentionally impacts the head, not a congenital injury or degenerative insult. Characterized by a period of diminished or altered consciousness. Range could be brief lethargy or brain death. The incidence and prevalence of this: over 1 million visits to the emergency department per year due to the suspected injury of the head. 18% of those children are between 0 and 4. 475,000 per year end up being a TBI. 100,000 of those children require hospitalization. So the leading cause of death and permanent disability in children between 1 and 19 years of age. Survival rate in children is greater than adults with TBI. It's 2 times greater in boys than girls, because boys are they're all over. All right, some causes of injury. The first one is a fall. This can be 35 to 50% of all pediatric TBIs, and they will require hospitalization or there can be death. Under 12 months is the greatest risk of injury from a fall. 0 to 6 months is the highest rate of moderate injury from falls. Motor vehicle accidents, approximately 25% of all pediatric TBIs. The most common trauma death is in ages 5 to 9, but then in ages 4 to 14, a lot of those injuries are from a motor vehicle accident when the child is on a bike or walking across the street. Another cause can be a gunshot wound. And then abuse is a big one. Abuse, 80% of head trauma deaths from abuse are in ages less than 2 years. Immaturity of the head and weak neck support, vulnerability. So they don't have a strong neck. Their head it's just not strong there. So the abuse is very large. Early identification of abuse is critical to prevent repeated incidences. So if you notice it, report it. Sports and recreational activity. This accounts for 29% of brain injury. Football, boxing, taekwondo equal half the injuries. Other sports that require head protection, and if it's not used properly or if they're not wearing it, such as baseball, horseback riding, or rugby, can be a cause of injury. Some mechanisms of injury, some acceleration, deceleration injuries. So moving head hit relatively fixed objects such as ground or the windshield. The windshield could be in the motor vehicle accident. A translational injury, head motion strikes stationary objects resulting in lateral displacement of skull and brain. Coup, counter coup, you guys remember what that is. Rotational injury, skull rotates as the brain remains stationary. Angular forces on the brain, surface contusion or laceration, and shearing trauma. Impression injuries, solid object impacts the stationary head. A rock or blunt object typically produces skull fractures and increased intracranial injury. Primary brain damage from trauma. So the first one, concussion. We've talked about concussions before, but a child may exhibit clinging behavior, sleep disturbance, irritability, and more distractibility than normal. So you can notice that a lot around the house. It may take longer time to recover than adults. Contusions, just a crush or a blunt trauma to the head, most common in the frontal and temporal lobes. Skull fractures, there's different kinds. So linear comminuted fracture, this is from low velocity objects, and then depressed fractures are from high velocity. And it's considered significant if it's greater than 5 millimeters. Intracranial hemorrhages is a common cause of clinical deterioration and death. Extradural hematomas is a tearing of an artery in the brain, most common in the middle meningeal artery and the branches of that. Unilateral hematoma, this can cause possible coma and even cardiac arrest in younger populations. Intradural hematomas, this can be acute subdural hematoma due to injury to veins in the subdural space, and there's a higher mortality rate and poor functional outcomes with these hematomas. Diffuse axonal injury, this isn't visible on a CT. Following a rotational injury is when this mostly occurs. They could have loss of consciousness, extensor rigidity in bilateral extremities, and also autonomic dysfunction. All right, so some secondary brain damage from trauma. So there's a lot here. It kind of breaks it down for you. So it evolves as a result of a pathophysiologic change initiated by the primary trauma. So first one, cerebral edema, increased intracranial pressure. You could have multiple cerebral infarctions, brain herniations, brain necrosis, and irreversible coma. Intracranial pressure, this can cause a brainstem compression and lead to difficulty breathing and cardiorespiratory arrest. Herniation syndrome, this results from a displacement of the brain by an expanding lesion. It also can cause hydrocephalus, which we'll talk about in a little bit, brain shift, passive midline, or brainstem compression. Hypoxic ischemic injury, so supply of oxygen and nutrients to the brain are dependent on an adequate cerebral perfusion. And neurochemical events, disruption of the blood-brain barrier and release of excitatory neurotransmitters and oxygen-free radicals to the blood system. Oxygen-free radicals are toxic and may cause brain damage and internal disruptions of neuronal functioning.
All right, so there's some consequences of brain damage. So you have hydrocephalus, which presents with altered mental status, nausea, vomiting, headaches, gait ataxia, and urinary incontinence. They'll have some communicating issues. All components of the ventricular system are enlarged, and the ICP may be intermittently elevated. It's seen in a vast majority of these post-traumatic cases. Now, non-communicating is an enlargement of the ventricles of the brain owing to the obstruction of the flow and impaired absorption of the CSF. Another thing is seizures. So frequency of the seizures activity within the first year may be predictive of reoccurrence. Then you have infections. Two common infections after a gunshot wound is meningitis as well as brain abscess. You can also have some fevers, headaches, confusion, neck stiffness, and increased ICP. Dysautonomia, which occurs after TBI in about 13% of children. And then you have endocrine disorders, which then you have hypopituitarism and precious puberty are commonly reported after TBI. PT should report concerns of weight gain and development of secondary sexual characteristics. So some predictors of injury severity and outcomes. So the clinical rating scales are used to standardize the description of patients with TBI. So they look at monitoring the progress, determine the general plan or appropriate medical intervention, predict outcome, as well as assist with the clinical outcome research. Now, the rate of recovery for TBI appears to be rapid in the first few months and can actually continue for the first few years. But obviously, the subsequent years after are going to vary based on the severity of your TBI. Some other predictors, you have the coma scale, which we know a coma is defined as the complete state of unconsciousness in which a child does not open his eyes or her eyes following commands or react to painful stimuli. Some things we use is the Glasgow coma scale, which we learned in our other classes, and then they also developed a pediatric coma scale. Then we look at the duration of the coma, which is directly proportional to the outcomes of worsening or longer coma. So the longer you are in a coma, the more worsens the outcome for a patient. Then we want to look at the depth of a coma, which is easy to access, which correlates with prognosis and functional outcomes. Then with orientation and amnesia assessment, so what a PTA is that it is an interval between injury and the moment in which an individual can then recall a memory from what is happening immediately. And they developed an amnesia test called the Children's Orientation and Amnesia Test. But these tests typically for children ages 4 to 15. They really haven't established one for someone under the ages of 4, but it's a pretty reliable method of assessment. And then you have the duration of post-traumatic amnesia, which the duration of PTA is more predictive of future memory function that the coma scale says. so it can help determine what the severity of a TBI is. So also we look at Rancho's Los Amigos, which we know is a descriptive scale of the cognitive and behavioral function. Then we look at the pediatric Rancho scale, which infancy is 7 years, enhances communication between staff. Obviously, we look at the age. The younger the child is, the more vulnerable to the effects of injury on memory than older. Then we look at their function, which the pediatric evaluation of disability inventory for classification of recovery of function. So walking is obviously the primary goal. Then there's 4 factors of non-ambulatory status at discharge. So prolonged loss of consciousness, lower extremity injury, impaired responsiveness, as well as the presence of spasticity. And then obviously environmental influences like family dynamics, parental distress and burden may impact the severity and outcomes of TBI.
Okay, so we're going to change gears a little bit here and focus on the examination. So in the subjective examination of a patient with a suspected TBI, you want to get a bunch of things. Like you need to know the mechanism of injury, how it happened. You need to know how severe it was, and any changes since that initial injury if they've been in therapy for a while. You need to look at the reports from CT, MRI, X-ray, and any other diagnostic test to determine if there's any underlying issues, any issues still, such as like hematoma that's lingering and that could be affecting your treatment or anything like that. You need to interview parents, siblings, and caregivers. That's kind of helping make the therapy family-centered. These people are the current experts on the child. Like you've never met the child before, so these people are going to be able to tell you what is and what isn't normal with that child. You need to evaluate the home environment, see if there's any conditions or limitations with that. Need to see if you have to make any necessary modifications throughout the plan of care, any necessary equipment throughout the plan of care. These patients are probably going to need some assistive devices or home modifications to make their lives more functional and help them with their independence. Need to interview a social worker to see if there's any underlying family or psychosocial considerations, whether the family's broken, if they have any strained relationships or anything like that. A social worker should be able to tell you that. You need to do a thorough systems review because with brain injury, so many systems can be affected. You need to use that to decide what will and won't be tested. So for the objective examination, you need to assess their cognitive and behavioral status. A full cognitive exam is beyond our scope, but you can do kind of a gross exam to help set realistic goals and make appropriate treatment decisions. You can assess their arousal and orientation, if they're lethargic, if they're drowsy, or if they're still in a coma. Some decreased level of arousal will interfere with your ability to follow commands and benefit from feedback. Assess their attention. They might have difficulty following commands. Once again, they might have difficulty relearning motor tasks, and they may be distractible. You may not be able to hold their attention the whole time throughout the treatment session. Their behavior and affect. If they're agitated or confused, that's going to be the most common, and we'll talk about how to treat that later. But what you could do is you could implement some rewards and reinforcements for desired behavior, and you got to be patient with them. If they're agitated and confused, they're not going to like being pushed along at the speed of a normal therapy session. You need to be patient with them and let them kind of go at their own speed. Their memory is going to be the most common cognitive impairment in TBI, not only in children, but in adults too. This is going to limit your functional independence or performance of ADLs. They may not remember how to do certain things from day to day, so you might have to reteach them. They may need retaught every single day. Language, they might have some receptive or expressive language deficits. They may not understand what you're telling them, or they may not understand how to express it to you. Executive functioning, this is a direct quote from the book. It's impaired ability to show initiative, plan activities, change conceptual sets, solve problems, regulate behavior in social settings, and use feedback to initiate behavior change. So if their executive functioning is impaired, all the other things we discussed are going to be impaired. And you're just going to have to be patient with them and take it one day at a time. So continued objective, you need to assess their sensory motor status, assess the tone of their musculature. whether they have unilateral or bilateral spasticity. Unilateral involvement kind of displays motor impairment similar to hemiplegic CP, which we had a presentation on. Bilateral involvement has asymmetric distribution and movements kind of dominated by primitive reflexes. So they might revert to some of those primitive reflexes that we've been learning. Abnormal posturing, they might have a flexor extensor synergy in one arm or both arms or the leg. They could have some decorticate or decerebrate posturing. So we would assess their spasticity with the modified Ashworth scale. They may have some ataxia, and that's due to damage to the cerebellum and basal ganglia. That could be unilateral, bilateral. It might be initially masked by their spasticity. If they're having spasticity issues, you may not be able to see how coordinated they are. It's characterized by a wide base of support and difficulty maintaining a static stance. We've all seen an ataxic walk. It's generally not associated with loss of range of motion unless it's combined with the spasticity. Muscle performance impairments, they're going to have some strength loss due to the prolonged bed rest. Initially, that might lead to some disuse atrophy, so you're going to have to work on getting them stronger. You need to observe their active movement during various tasks and judge their ability to move dynamically against gravity and statically sustain weight. They're going to have some impaired endurance. They might be in an overall state of lethargy just due to the shock that their system has endured. They're going to have physical and mental fatigue. If they're having to work so hard to understand what they're going through, and their brain is working so hard to keep up with the therapy session, they're going to be mentally fatigued as well. So you need to incorporate rest breaks within the sessions and between therapies. They're going to have some range of motion loss just due to the immobilization initially and some of the abnormal movement patterns like the synergy patterns or decerebrate and decorticate positioning. Elbows, wrists, fingers, knees, ankle, and feet are particularly those that are at risk. Balance and control postural loss. Even in mild TBI, a loss of the balance prohibits safe participation in pre-injury activities for over 12 weeks following the injury. Sensory deficits, you probably want to refer them to an audiologist for a thorough hearing evaluation if you think they're having troubles hearing you. Vision, they're going to have decreased visual acuity, issues with pursuits and accommodations, visual field cuts, depth perception problems, double vision. They might have some transient cortical blindness, and maybe some retinal hemorrhaging. So eye patching, glasses, preferential classroom seating, and all sorts of visual therapies can help with that. You might see if they have any visual spatial skills. They might have, because of a lesion in the temporal or occipital lobe, this may impair gross motor performance and functional mobility skills. They may have some figure ground deficits. They might have some problems reaching into a drawer and picking out scissors or pens. This is something you can work on them with. They might have a difficulty developing a mental map of their environment. They might get loss frequency, so that's going to inhibit their independence and going to make them more reliant on assistance. Some orthopedic complications that are listed include heterotopic ossification. This is common at the elbow, shoulder, hip, and knee, and then fractures. Fractures are commonly during the trauma, especially if it was a car accident or anything like that. It would be like a pelvic or lower extremity injury. So some functional measures that we can use to evaluate these patients are the Alberta Infant Motor Scale, and this is gross motor function in 0 to 18-month-olds. And then you can progress them to the WEFIM, which is basically a children's functional independence measure. That is reliable from 6 months to 7 years of age. And then you can just use the adult FIM in older children. Gross motor function measure is more commonly used in children with cerebral palsy. And this is also followed by the acquired brain injury challenge assessment. And that challenges motor activities beyond what the gross motor function measurement examines. You could examine their walking speeds. If they're ambulatory, they're going to have a reduced range of walking speeds in TBI. In TBI, it's 73 to 154 centimeters per second. And in typical development, it's 54 to 193 centimeters per second. So they're going to be walking a little bit slower. You could also do a 2-minute walk test or a shuttle walk run if they're ambulatory, and that's in higher level. So evaluation, diagnosis, prognosis. Evaluation, we're going to want to weigh their observed impairments with the knowledge of their condition to better understand how they're going to progress throughout therapy. We need to consider all of the environmental and personal factors such as social support, home environment, school. You need to consider the amount of time that's passed since the injury, the interventions they've received since then, and the progress they've made to determine how much more progress they're going to make. Formulate your physical therapy diagnosis based on the findings. So lower extremity hypertonicity, brain injury severity, and lower extremity combined are critical predictors of ambulation ability. So if all of those are very severe, then they're not going to be as ambulatory following therapy. So dysautonomia associated with prolonged rehab it's associated with prolonged rehab and lower motor scores. For all of TBI patients, the expected range of children visit numbers is 5 to 90 sessions. So it's highly, highly variable. So the plan of care, you want to do retreatment interventions to address the muscles, the spasticity, the core or the cognitive deficits, the visual deficits, all of that. Need to make short-term and long-term goals based on those deficits. And the time frame is completely dependent on consideration of their cognitive and behavioral status. It's highly variable depending on each case. And if you've seen one TBI, you've seen one TBI. None of them are going to be exactly the same.
All right, so some treatment and intervention strategies. First one, coma stimulation program. So you can stimulate the auditory system, visual, olfactory, tactile, and vestibular system. They may not respond, but when they do, you can look for the startle reaction, blinking, grimacing, or head writing. Some things you can use are some vinegar, pictures, just gentle tactile cueing, music. When they're agitated, this phase, you want to utilize the team approach. So get the family involved, other healthcare professionals involved. You want to try to do this in a quiet room. So turn the TV off, try to keep the cell phones minimal, things like that. And you want to protect the child from potential injury. They're going to be angry. They may do things that they're not supposed to do, which can cause potential further injury either to the head or different parts of the body. You want to modify the treatments. You want to keep them simple, and you want to keep them familiar to the child. That's very important. So keep them simple and utilize the team approach with this with the family. The confused stage, you want to decrease the complexity of the instruction. So keep everything simple. Once again, we're keeping everything simple. And you want to give as much structure and assistance as necessary during this time. So you can help them out during this time. That's perfectly fine. The more assistance, just to get them more practice and working towards the overall goal, is the main objective here. Some higher functional exercise. So step downs, you've seen those a lot. Works on eccentric control and lower extremity. Lunges, treadmill training for gait. That's a good one. The BAPS board, this is for lower extremity coordination control. The Swiss ball exercises, so you can work on core strength. They can sit on the ball. You can have them turn. You can have them reach for things. Just sitting on the ball help with core strength and coordination. The bike, that also works. Helps with the lower extremity. Can work with endurance and things like that. And then once you start getting higher, you can start doing stairs. So we're kind of going up the stairs, down the stairs, slow controlled movements. And then later on, you can start incorporating sports. You can have them swing a bat, throw a ball, kick a ball, things like that. Things they like to do to get that motor function working even more.
All right, so for school and community reintegration, that's something that you definitely want to take into consideration, is because it can be pretty overwhelming. But if you do it right, then things will go well. So with school, the classroom environment may be very difficult, especially with, other students. Learning can be very overwhelming. So some children may have some vision issues, memory issues, concentration, impulse control, as well as organizational skills, which can definitely overwhelm the child. Now, with continuing treating with the residual motor deficits that interfere with functional independence, they will need assist devices and assistance for basic motor skills. Now, when they get to the higher level, then they'll use like balance boards, carrying objects, running, jumping, hopping, skipping, etc. And then with the Individuals with Disabilities Education Act, or IDEA, school curriculum can be adapted for children with TBI. So definitely look at reaching out to those programs or those things that will help children in the classroom or in the community with adapted ways to learn, as well as accommodate any physical assistance that they may need. Now with prevention, children under 12 are a huge risk. So when kids are going out playing, especially on movable objects such as bikes, skateboards, scooters, you want to make sure that they have helmets and that the helmets fit properly. If they don't fit properly, then they may not provide the necessary cushions for protection of the head. Obviously, you want to prevent kids from falling on the playground. So observing any sort of dangerous acts that children may do, because they're kids, they think they're invincible and they can do whatever they want to do. So definitely watching out for their behavior, traffic behavior. So making sure you look left and right before crossing the street, because people may not notice or see a little kid or anyone really or pay attention. And then definitely number one is wearing seatbelts in the car. For any sudden stops, any potential accidents that may occur. Seatbelt is definitely a way that you can reduce the risk of injury or having a TBI.
So we included a video. We're not going to watch it here in the PowerPoint. This summer in our adult neuro class, we had a visitor. He was in he had a football injury, and he just collapsed on the field, and it turned out that he had sustained a traumatic brain injury. James McGinnis is his name. And here is kind of his story. They've got a YouTube channel with all of his rehabilitation videos if you're needing any ideas for treatment or examination or anything like that.
And for our research sources, we just use Techlin, so straight from our textbook for any further information on things we covered in this topic. Awesome.